a second. We are doing this on live stream to Facebook. So good evening, everyone. Thank you for joining us today. My name is Savina Chacheva. I'm the program manager at the Cancer Wellness Center. Tonight's program is a part of the Cancer Wellness Center's Men's Health Education and Support Series, which is funded in part by a donation from Astellas. The evening, we'll be talking about improving intimacy and sexual health after cancer. For those of you new to the center, we're a nonprofit organization that provides free supportive services to those impacted by cancer and their loved ones. Programs include educational programs like the one this evening, wellness classes, and support services. If you would like to learn more, please visit cancerwellness.org. Before we get started, just a few housekeeping items. Please note that your audio and video is disabled for the program, but please feel free to submit questions through the chat feature. We'll be answering them as we go, and then we'll get an opportunity at the end once we stop the Facebook Live to unmute and ask questions. After the program, you will receive our evaluation. If you could please take a minute to complete that, we are very appreciative and welcome your feedback. Now, without further ado, I would like to welcome our presenter, Dr. Jeffrey Albaugh. Dr. Albaugh is an internationally recognized speaker and expert. He is a board-certified advanced practice urology clinical nurse specialist, researcher, and director of sexual health at NorthShore University HealthSystem. In addition to his role at NorthShore, he has led the sexual health clinic at the Jesse Brown VA Medical Center in Chicago for over a decade, serving our veterans. He previously worked at Northwestern Memorial Hospital for over 25 years. In addition to his publications in peer-reviewed journals and chapters in books on sexual dysfunction, Jeff has published the booklet called Understanding Erectile Dysfunction, Patient Evaluation and Treatment Options for Healthcare Professionals. So we're really excited to have him here this evening. He is very much an expert in this field. Welcome, Dr. Albaugh. Thank you for coming today.
Thank you so much. And thank you all for your patience. I'm so sorry. I finished my very busy clinic day and we were trying to get this set up. So I had to move to a room. So if you see this strange background, this is just one of the few offices that has a camera and it's in one of our manager's office. So just ignore that. But basically, I don't think there's anything important back there. But basically, we just wanted to give you this information and I had to do it from my clinic. So thank you for your patience. I'm so sorry. It's a little bit of technical difficulties and you've done a wonderful job of hanging in there with us. And hopefully it's going to all make sense to you and it's going to be really helpful. So welcome and thank you for your patience. Let's go ahead and advance the slide. Okay, so I have no disclosures except that I'm very committed to improving quality of life in men and women who struggle with sexual dysfunction. And that's pretty much my only disclosure. We can go to the next one. Okay, so why is this so important? I know you guys asked me, and I have spoken at this center before a few times, as well as other cancer centers around the Chicago area. So why is it so important to deal with intimacy and sex? And I think it's important for us to remember it's not just about sexual relations. It's about intimacy and connectedness with others. So when we look at should we be connected with others, we learn from some of the research out there. There's a whole book by Daniel Goleman. You've probably heard of emotional intelligence before, and Daniel Goleman wrote a whole book on it, but he followed it with a second book called Social Intelligence. And in that book, he talked about how each of us, you, I, all of us, we are hardwired for connection to other people. And so when babies don't connect to their parents or a loved one or somebody, they actually die. They call it failure to thrive. So you and I, all of us, are hardwired for connection with other people. And connection is that energy that exists when you feel seen, heard, and valued by others and not judged. And connection is a really important thing for all of us. So it's not just about the act of sex or sexual relations. It's also for many, many people about intimacy and connection, especially with that special loved one, that person in your life that you're sharing these things with. If you ever went to college and even in high school, you probably remember Maslow's hierarchy of needs. Do you guys remember that? I learned it multiple times. And when you look at the different needs, basic needs like food, oxygen, water, believe it or not, love and belonging is a basic need of human beings. So again, we need to feel love and belonging with other human beings. Sometimes we think, no, I'm okay. I don't need anything. I don't need any connection. I don't need anybody. But believe it or not, science says that is not true. You do desperately need to have connection with other human beings. But vulnerability is scary. And so we shield ourselves when we feel vulnerable. And Brene Brown has done countless research with thousands of people. She's written multiple books, The Gifts of Imperfection, Daring Greatly, Rising Strong, and she's looked at vulnerability and shame. And she says one of the most vulnerable things for each of us as humans to do is engage in intimacy and sex with a partner. So that puts us in a very vulnerable spot. Let's go ahead and advance to the next slide. So when we think about, well, what is sex and intimacy and why is that, why are we talking about it? Well, there's some intrinsic characteristics, things that we were born with in terms of sex. Our sense of being male or female, our sexual anatomy, different things that we were born with. But sexuality is multidimensional. It's not just the genetic things. It changes over life. It's dynamic. What you thought sexuality was when you were 5 versus when you were 12 versus 20 versus 40 or 80 could be completely different. So it's dynamic and it may change as you move along. It's individually derived. What you think sex is, each one of you, Carrie, Zoma, different people who are on the call, as well as Sabina and myself, we all would probably describe it just a little bit differently. It's individually defined and experienced, but culture plays a part too. So when we think of what we think about sexuality, like when do people first lose their virginity? It's very different, the average age of that in the United States versus in China and other countries. So it's culturally derived too. So there's lots of things that go into it. Almost everything on the face of the earth affects sex. So when you come in, unfortunately, we ask you anything and everything because we're trying to understand exactly what all is affecting your sexual function. So your religion, and you may think, well, how could religion? But believe it or not, there are religion cultures where people actually are sitting outside the room while marriages are being consummated. And you can imagine how that might be traumatic and difficult on a couple or people. So culture plays a big part in it, but many things go into it. Your religion, your culture, your medical issues, your health, so many different things can affect sex. But for our purposes today, let's define sex in particular as any kind of genital stimulation for pleasure that you do with a partner. So partnered activities where you have genital stimulation for the purposes of pleasure. Intimacy goes hand in hand with this. Intimacy is the process by which two people attempt to try to communicate on a deeper level, verbal, nonverbal, but on a deeper level. So intimacy can be part of sex, and sex can be a part of intimacy, and often they go hand in hand and work in tandem, but not always. So if you were fighting with your partner and disagreeing, and you were having a pretty good disagreement, and so now you're not really speaking, could you still have sex? Physically, yes, you could still have sex. It would be possible, but could you have intimacy, communication on all levels? No. If you're not communicating on a basic level, you probably couldn't have intimacy along with the sex. But often, what my patients tell me when they come in, they're not only looking for help with sex, but they're looking for help with intimacy, connectedness with their special loved one, that special connection that exists between them and that partner. It may be in a monogamous relationship, it's usually, this is something only we share. I don't share this with anybody else. We have this intimate sexual relationship, but it's intimacy and sex together. So it's a connectedness that you feel with your partner. And people are looking for help with that connectedness, that intimacy, and also with the sexual function part of it. So I like to expand that a little bit so that you're thinking about it. Let's go to the next slide. And you'll see lots of different people underneath. You'll see all of this is based in science. This is not just what I'm telling you. Remember, I have a PhD in sexual health research, so I'm always looking to science to tell me, what does research show? What's real, what's not real? Even though personal experience is incredibly important, I also look to the literature and the science and the research to see what it says about it. So what is sexual dysfunction? It's just the persistent impairment of a couple's normal or usual patterns of sexual interest or response. And this is from the American Foundation on Urologic Disease, and also from Basan. And so again, this is just kind of the definition. Let's move on to the next slide. When we look at Masters and Johnson, which is more of a male-dominated model, Masters and Johnson, believe it or not, now I do a lot of research, and my research is considered to be pretty sensitive. So I get dinged a lot by the IRB. Are you being careful about this and that because your research is sensitive? Masters and Johnson literally watched people have sex, and that's what their research consisted of. I think, wow, I don't know how you get that through an IRB or how you get that approved these days. So I don't know that we'll ever get to learn what we learned from what Masters and Johnson literally taught us. So this is sentinel, important research from a long time ago that will probably never be repeated. But they watched people masturbate, they watched people have sex, and they learned what happens when people orgasm. How do people get excited? How does the whole thing go? And they said it all starts with excitement. It starts with your pulse increases, your sensation on your fingers and toes. You start to feel more. Tactile sensation increases. Your blood pressure may increase. And that's part of excitement or desire. And then that sort of builds and builds and builds. And you don't want it to build endlessly. That wouldn't be good. And then it plateaus. And you get to a place where you're like, this is really exciting. It feels really good. And I like to hang out in this plateau area right before orgasm. A lot of people feel that way. And then orgasm occurs, and then resolution, and it's over. That's the male model. But in the female model, the orgasm may occur, and then if stimulation continues, they may be multi-orgasmic, and that may go on for longer. And you can see from my slide, how long does that take from start to finish without trying to stop it or trying to control it in any way, shape, or form, especially with like masturbation or whatever. And for men, it takes an average of 3 minutes, 2.8 minutes. But do you all see a problem with this? For women, it takes about 13 minutes, 4 times longer. I don't know if anybody else sees a problem there, but that's a problem. So if women take 4 times longer, that's something really important that men have to know and understand when we're partnered with women. And not all men are partnered with women, but when you are partnered with a woman, you need to know it takes her 4 times longer to climax because the clitoris and penis are very similar organs, and the clitoris is more internal. So it takes more work to stimulate and arouse a woman in general. These are generalizations than a man. So Masters and Johnson learned all this cool stuff through this research they did. They did a lot of crazy things too, but they really gave us some wonderful information. Let's go to the next slide. And you can kind of see how it works. It starts with, look on there at this. I don't know if you can see my points or not, probably not, but it starts with desire, and then it builds to arousal, and then plateau, orgasm. For the woman, they may be multi-orgasmic, and then it resolves. Let's go to the next slide. So I'm going to talk about this in just a second, but Rosemary Bassan, who is a OB-GYN, actually looked at that model, and then she tried to apply it to her women. And what she found was 1/3 of the women in her study said, no, it doesn't start with excitement or desire for me. So this is another really aha moment for men and women to realize. She said, it doesn't start with excitement or desire. It's not like this drive for that. This isn't all women, but this is a good 1/3 of the women. And they said, it starts with emotional engagement. You have to engage me. I have to feel a link and a connection, intimacy with you. And then that later leads to some desire, arousal, different things like that. So I think that model from Rosemary Bassan is really important too, because I think for some men and women, it doesn't always start especially when you're on androgen deprivation therapy and your testosterone is in the tank, it doesn't necessarily start with desire. It may start with connection, and then desire builds later. Remember, women have 1/10 of the testosterone men do, so there's a lot of things to keep in mind why it might have been different. But boy, talk about a researcher's nightmare. Here she has this model that she's using for her research, and 1/3 of her patients say that model doesn't fit me. It doesn't go that way for me. These next couple slides, all they're to do is to tell you that most people with cancer have problems with sexual function. And you can see from this first slide, 70% of the patients after cancer treatment say that they have some sort of sexual dysfunction issues. And you can see our list there. I don't have a desire. I have a lack of desire, and it's not pleasurable anymore. They may have if they have pelvic or genital radiation or surgery, they may have dysfunction down in the genital area. Lack of lubrication for women. For men, it equates to erectile dysfunction. They may not become erect. They may not be able to climax if the pudendal nerve was involved. Chemotherapy affects hormones. It affects desire. It affects ability to climax. It affects erections, lots of different things. Some of the other medications that you're taking, sometimes because of the depression or the anxiety, those medicines may affect sex as well. Treatment side effects from your chemo, from all the different things you go through with cancer treatment, fatigue, feeling bad, pain, stress. And so sometimes you're like, sex isn't even on the radar for me with all that going on. But I know it's probably on the radar for my partner. So those are things that sometimes as people are going through cancer treatment that they're concerned about and worried about. And then there's all the psychological issues. And again, I just give you some of the studies that support all those things I'm saying below it. Let's go to the next slide. And I'm just going to talk about prostate cancer and how 80% of those men at 2 years and 72% at 5 years say, I'm struggling with erectile dysfunction. I am having trouble getting or keeping erections. This is from a study. But then look, several years later, there was another study by Resnick that said the same thing. 80 to 87% of patients who had radical prostatectomy, and the same thing happens with radiation, the same study found out too. 2 to 15 years after treatment, were struggling with sexual dysfunction and especially with erections, getting and staying hard enough for sex. So that means most of the men who have any kind of cancer treatment for prostate cancer are struggling with sexual dysfunction because the prostate's part of the sexual reproductive system and the nerves are right down there in that area where they're doing surgery or they're doing radiation. So the men describe the impact. They say, my gosh, it feels like a light switch was turned off. And literally, before the surgery, I could have erections. Afterwards, I couldn't. Or, gosh, slowly over time after the radiation, I stopped being able to get and keep erections. But the number one complaint, and it happens in the big majority of the men, like 80% of them, especially initially after surgery and later after radiation, complain about sexual dysfunction issues. So this is the most common non-skin cancer in men. So when we're thinking of what's the most common cancer in men, it's prostate cancer. And those men, when they're treated, almost all of them are struggling with sexual dysfunction. Let's go to the next slide. And again, how about colorectal, which is one of the other more common cancers in men and women? And you can see sexual dysfunction occurred in 60% of the women and 54% of the men after rectal cancer treatment said they were struggling with erectile dysfunction. The majority of men who had treatment for colorectal cancer, you can see in the bottom study, about 66% of them, 2/3 of them said, I'm struggling with erections, getting and keeping erections. So you're seeing this recurrent theme that when you have cancer treatment, many men, it's not unusual to struggle with erectile dysfunction, getting and keeping erections, or other sexual dysfunction problems. Let's go to the next slide. Thank you. You're doing a great job, Savina, of keeping up with me. So now we know, wow, with treatment for cancer, chemotherapy, sometimes radiation or surgery too, most patients, and we're talking like 70–80% of the patients, complain about sexual dysfunction issues, whether they're male or female. That's really important to understand. And you should know that going into treatment so you can be prepared for that. You and your partner both need to understand that. And that's why I typically see patients before they have prostate cancer surgery. And I like to see them before the problems are occurring so greatly. Now, remember, too, as men get older, in your 60s and 70s, a good percentage of men might have erectile dysfunction or sexual problems anyway from other disease processes like diabetes and high blood pressure and cholesterol and head, neck, and back issues and so many different things. But cancer treatment does greatly impact fertility as well as sex. I didn't put a lot in about fertility, but that's also another really important. If you're still in those years where you're wanting to have children and stuff, you want to think ahead of time about how you're going to preserve some of the ways to do that. If you're past all that, that's not a worry. But what the Live Strong study found was many people struggle with infertility, and that often they're not given the information they need ahead of time to deal with those fertility issues ahead of time. And that's super important, because if we're going to preserve sperm or eggs or even fertilized eggs, we got to do that ahead of time. We got to know ahead of time before we radiate testicles and pelvis and different things. So, or in women, all those things. So lots of things to think about and be proactive about before the treatments occur. What do we do about after the treatments occur and people are suffering? Well, there's lots of different treatments for sexual dysfunction. That's really important for all of you to understand. There are multiple treatments. Of course, sometimes just like this, learn about sex. And we're going to talk about some of those counseling behavioral therapies in just a couple minutes. And we talk about that with patients all the time. And then for men in particular, this is a men's series, so I'm not going to focus on the women with this, but that's a whole nother talk or big discussion as well. But there are vacuum devices where you put the penis inside a vacuum, and as you pump the vacuum, it forces more blood in the penis and makes it hard. And then once it's hard, you transfer a ring off the edge of the device to the penis, and then you're able to get your penis out of the device and into the vagina. The vacuum brings more blood in to make you hard. The ring traps the blood so you can get it out of the device and use it for intercourse. There's pharmacological agents. There's pills. There's a pellet that goes down the urethra after you urinate. There's a shot that goes in the side of the penis every time you want to have sex. So there are drugs that help you with erectile dysfunction and sexual problems. There are surgeries, a penile implant surgery. There are different things they can do. In some cases, not always, there's so many herbs out there that people say, this will fix everything. This will make you bigger, longer, harder, right? All those things. Well, wow, if it made you bigger, probably every man in the country would be like, well, sign me up, because who wouldn't want to feel almost every man on the face of the earth comes into my office and says, I don't think I'm very big. And even if they are, they don't think they are. So, but in general, I would advise you highly to stay away from herbs. Most of them don't work. A lot of them have literally been scientifically studied and shown not to work. There are a couple, like Korean red ginseng, Panax ginseng is one, and like L-arginine or L-cysteine is another one that can be carefully used sometimes, and sometimes they will help. They don't typically work as well as the pharmacological agents, but they can be helpful in some cases. But there's only a few that have scientifically been shown to work, and we do use those sometimes with patients, and patients do use them and have some success with them. Most of the stuff you try, you'll find is useless and does nothing. Believe it or not, some of the stuff will do crazy things. And I've had men say, I bought something in a gas station and I had a 3-day erection, which is literally a medical emergency and not a good thing. It may sound like a good thing, but trust me when I tell you, it is not a good thing. Because when blood can't move back and forth, tissue dies, and you do not want tissue to die in your penis. So what that happened because he took some crazy thing that had God knows what in it from some gas station. So really be careful of some of that stuff out there and make sure that you're looking for science to support whatever you do. just like the other things that we do. And there are a few herbal things that have some science, and in particular, the Korean red ginseng. But remember, ginseng can thin your blood, so you should talk to your doctor about all these things. Don't just start things. L-arginine and L-cysteine, which can be helpful with blood flow there too. They don't work as good as the other things I'm going to talk about, but especially in some of the less severe, in the milder erectile dysfunction, they may be helpful. Let's go to the next slide. I'm going to talk a little bit about a few of the therapies, but first I want to talk about some of the behavioral and educational things. So, okay, guys, and if partners are with you on this call, I love that your partner's with you today. That's awesome, because everybody's welcome to learn this information. So, okay, why are we, let's say that we're done procreating. I'm done procreating. My babies are 25 and 27. My sons are grown. We're not doing that anymore, okay? So now, why are we having sex? Well, of course, like everything else, that's been studied. And the reasons are, there's lots of reasons, but the main ones are, number one, connectedness. To feel connected on a deep, profound level with the person that you love or want to be with. So connectedness. Number two, pleasure. Remember, and maybe when you have problems, you forget this, but sex is supposed to be fun. It's supposed to be pleasurable. So it should be enjoyable and pleasurable. So it's about pleasure and it's about connectedness. If you're freaked out and you're anxious, you can't have good connection and you're probably not having fun. So anxiety is definitely one of the worst things to bring into the sexual experience. Plus the fact anxiety causes adrenaline to rise and is part of your fight or flight response. So if you start getting anxious and you start thinking, is it hard? What's it doing? What does she think? Oh my God, this is horrible. What's going to happen? Trust me, you don't even have to look down. You are going to lose your erection, because the adrenaline will cause a fight or flight response, and the blood's going to go to your brain. It's going to go to your muscles. It's going to go to your heart and all the places that are needed for fight or flight, and not your penis. You don't even have to look. I can tell you it's going to move out of your penis if you start getting really anxious. So staying focused on sex is super important, and not getting anxious. And remember, it's about pleasure. It's about connectedness. It's about sometimes it can be about orgasms. It doesn't always have to be, but it can be about orgasms. And there are many, many ways to experience sexual pleasure and many ways to reach an orgasm besides intercourse. Intercourse is one way. It's a wonderful, lovely way, but it's not the only way. But you have to be hard to penetrate a vagina or rectum or whatever you're having intercourse with. And you have to be hard enough to do that to have intercourse. You don't have to be hard to have an orgasm, to have connectedness and pleasure. Remember, orgasms happen from the pudendal nerve system, and that's separate from the cavernosal nerves that give you erections. So the pudendal nerves are usually not majorly impacted. So after prostate cancer treatment, which majorly affects erections, most men can still climax, even though nothing comes out because their prostate's gone, but they can still climax because they're wired separate. In fact, most men with erectile dysfunction can still climax because it's usually a blood flow problem more with erectile dysfunction in most men. So even though the blood doesn't flow in the penis and mechanically they don't get hard, they can climax fine because the pudendal nerve is intact and they're doing okay with that part. So you can have orgasms, you can have pleasure, you can have connectedness, whether you're hard or not, through manual stimulation of the penis, manual stimulation of the clitoris, oral stimulation of the penis or the clitoris, oral stimulate vibration of the penis or clitoris, rubbing genitals together. There's so many ways to have connectedness, pleasure, and orgasms. So here's the thing. You can do all those different things. And if you get in the mindset, oh boy, what just happened? Why did that do that? Oh.
We can hear you, okay?
Hold on, my screen. Oh, wait. Can you still hear and see me?
Yep, we can hear and see you. Yep.
Okay, let's see. What is this caps lock on? That's fine. I don't know why everything disappeared for a second, but there we are. Okay, sorry about that. All of a sudden my screen went to something totally different. So think of it like a dance. You love to dance, and your favorite dance may be the tango, which is intercourse. But what about the cha-cha, the merengue, all the other ways to dance? You don't have to be hard to do all the other things. And if you can get yourself in a mindset where you're going to, all sex is good. And if you can have connectedness, pleasure, and if you want orgasms, whether you're hard or not, then there's lots of ways to do it. So if you're hard enough, then you could have intercourse. If you're not hard enough, you could have outer course or non-penetrative sex. Sometimes the excitement comes from, we kind of get rogue in the way we approach sex. Okay, I touch you here, I touch you there, and then we do this, and then, okay, now everybody had an orgasm. Are we done? Good. That's not real exciting. So now the excitement comes from, what will we do this time? Will we have intercourse? Will you have an orgasm and not me? Will I have one and not you? As long as we both agree and are comfortable with it, all of that can be wonderful and cause connectedness and pleasure. Intimacy, connectedness is important, and you lose connection when you get frustrated, angry, or upset. And you also lose pleasure. So, and those are the two main goals of sex if you're not trying to procreate. So that's really important. Let's go to the next slide. So relationships are a big deal too. Maybe you have that special relationship. I've had that relationship. I've been married 35 years and with my wife at least 37. And so if you're blessed and lucky enough to have that connection and intimacy, it's a lot of work, but it can be a wonderful thing. Life is difficult. And typically what happens is, when my life's difficult and my life's crazy at work, the person who bears the brunt of it sometimes when I get home is my wife. She's the last person who should, but sometimes my crabbiness, my moodiness, all those things, my upset, my frustration, my anger with whatever. I'm a cancer survivor as well. I've had two different types of skin cancer, including melanoma. And then I also, very early in life, at about 29, wasn't sure that I was going to live much more at that point either. So I've definitely dealt with my own life-threatening illnesses. And I can tell you that puts a lot of anxiety and pressure in your life. And sometimes I think I wasn't the easiest person to live with. My wife has gone through difficult things, and we tend to take that on the people we love and trust because we feel safe. But they're the last people we should or want to take it out on, but they bear the brunt of it. So a lot of my partners and my patients say, we live this prostate cancer or this cancer thing together. We go through it together. We live it together day in and day out. And it affects us both greatly. So I think it affects the relationship. And so that's why I really try to get partners involved with what we're doing with treatment. So if you're in a relationship, you have to learn to accept and adapt to the idea that there's more than one valid reality. That your reality of what you saw is valid, but so is your partner's. My wife and I, she's very much a detail person, and I'm a big picture person. I will tell you that literally we will walk out of the same room and start talking about what we heard, and we're like, we were not in the same room. There is no way we were in the same room, because that is not what I got out of that. Because we sometimes process and receive things so unbelievably differently. Was she wrong and I'm right? No. Am I wrong and she's right? No. Both of us have gleaned and learned different things, and they're both valid and they're both real, and we have to respect that. So we can improve relationship. We can improve life satisfaction, and sometimes that's what we work on. I do a lot of couple therapy over at the VA where I work too. So we work on relationships, and relationships can get better when we work on them. Let's go to the next slide. So if we're hardwired for connectedness, and what most people want more than anything is intimacy and connection with other people, this is what the research says, but vulnerability is scary. So we say, I'm going to numb, I'm going to shield, I don't want to feel anything. All day I've worked with patients, I'm going to go home and I'm going to watch TV and numb, or I'm going to go to the store and use my credit card and I'm going to numb, or I'm going to have a drink and I'm going to numb, or I'm going to whatever and numb. There's so many ways to do it, but we can't selectively numb. That's what Brene Brown said from her research. So when you numb, you also numb all the other things that vulnerability brings. And guess what? Vulnerability is the only path to connectedness. It's the only path. It's the only path to love and creativity. It's not just the path to pain and hurt and sorrow, but it's the path to connectedness, love, and creativity. So when we numb, it all numbs. So that's why it's so important that we do have to have some vulnerability with our partners. Let's go to the next slide. And so what are the goals of sex? If it's intimacy, if it's communication on all levels and connectedness, and it's pleasure, I've kind of driven this point into the ground. There's lots of ways to get there, and it doesn't require a hard penis to get there. That's one way, but it doesn't require that. So communication is really important. We have to start talking about sex because we usually don't do that. And if we don't talk about sex, and we don't usually this is the extent of our vocabulary. Yes, yeah, right? It's not sentences about, you know what? I'm struggling with this, so maybe we need to do that. And maybe that doesn't happen in the bedroom when you're trying to have sex, but maybe that needs to happen outside the bedroom so we can talk about, I'm scared I'm going to hurt you when we're having sex. And then we can talk about, you're not going to hurt me. We'll do this. We'll do that. I know you're worried because I had these cancer treatments and you think you're going to hurt something, but my doctor has told me you're not going to hurt anything. Or you come talk to me and I'll tell you you're not going to hurt anything. But we have to start talking about it, but we're not used to talking about it. And we'll never get used to talking about sex unless we start talking about it. So that's why I kind of usually talk about, let's talk about sex. You've kind of heard that. I think it's a really important thing that we talk about sex. But guess what? When it comes to sex, it's everywhere. It's on the billboards. It's everywhere around you. But what's so crazy is nobody's talking about it because of vulnerability and shame. But we got to talk about it. So that's why I'm talking about it every day. Angelica, the nurse practitioner who's here listening, she works with me in the clinic. We're talking about it every day because this is what we talk about and help people with because it's a part of the human journey. It's just part of being a human, and it's something that people need in their lives, intimacy and sex. So let's go to the next slide. So what can we do about it? We have a couple treatments, and I'm just going to touch on some of them, and then I'm going to open it up to your questions. We have oral agents. We have Viagra, LeVitra, Cialis, Stendra, Staxyn, lots of different things. Now remember, in general, these have to be taken on a pretty empty stomach because food and fat will delay absorption, and they have to be taken for the classic three, Viagra, LeVitra, and Cialis, they have to be taken at least an hour ahead of time if you want everything it's going to give you. Now, it may start working in 30 or 40 minutes, but if you want everything it's going to give you, you got to wait an hour and a half for the full effect of most of these drugs, and that's when you take it on an empty stomach. So those are some important little pearls to help you use those better. The new one, Stendra, gets in actually in about 10 to 15 minutes, and it peaks in about 30 minutes, but it's gone in 3 hours. Nothing ever outperformed Sildenafil Viagra, so that's why it's still the most popular, but some of the others work equally well, like Tadalafil, Cialis, but that one lingers 4 times longer. So sometimes it can be helpful if you want it to stick around your body longer, that would be the medication. If you're fine with it being gone in about 8 hours to a half a day, then Sildenafil or LeVitra are fine. If you want it out of your body really quick, Vardenafil, Stendra. So it's kind of working with your healthcare professional to see what fits you the best. They all work pretty equally well. So in general, after your treatment, if you find one of them doesn't work, I would lay money. You'll probably find none of the rest work either because they work the exact same way. And if we look at the research, they work pretty equivocally. Once in a while, most patients say they work equivocally. There's no difference. I don't see that much difference. None work better than the others. But once in a while, I'll have people say, for whatever reason, this one works better in my body. But I have just as many people who say that one works better in my body. That's why after working with thousands of patients, I will definitely tell you they all work pretty equivocally in general. But they may work a little different in your body. But there's ways to take them for the best effect. There's lots of little nuances to them. I can answer your questions about them. But sometimes after some of the treatments, they don't work that well because of the nerve connection between your brain and your penis, which has to be there to communicate back and forth so you can get erections, and the blood filling and engorging your penis. Nervous conduction and communication are the two critical pieces to erections. And sometimes that's not working well after whatever treatment you had. And that's why the pills aren't working well either, because they rely on those things. So anyway, let's go to the next slide and I'll answer your questions because you may have a lot of them about oral agents, but I just wanted to touch on it. I talked about the vacuum pump. This is what it looks like. You put your penis in the cylinder, you pump it up, the ring holds you hard. It's basic physics. And if you learn right and someone knows how to teach you how to use it right, it almost can't not work. It works in 80–90% of patients. It forces more blood in your penis, and then you trap it with the ring. But if you don't learn how to do this right, it's going to be a whole hot mess, as you can imagine. And two, how do you incorporate this into your love play? You may be thinking that, right? So you might be thinking that, oh gosh, how do I introduce this with my partner? Well, there's lots of different ways, and we kind of help you try to figure out how to do that. Maybe you want to, some men like to step away, have it already in the bathroom and use it. Some men, their partners help with the pumping and the vacuum pump. There's lots of ways to do it. It's far from perfect, but it is non-invasive and it does work in most patients, but it's cumbersome, it's awkward. Everything has its good and bad. I try not to persuade you or dissuade you on anything. I try to just give you the facts you need to know to make your own informed choice. And this has good and bad, but it is the most popular by a landslide is pills. Nothing even comes close to it. But the second most used thing when pills don't work, well, the second most popular thing is outer course, because some men are like, I don't want to deal with a vacuum pump or shots or anything. And there's nothing wrong with that. That's fine. But if they do go to something else for erectile dysfunction, this is number 2 most popular thing. Go on with the next slide. And so then there's injections, which sounds like one of the scariest things probably you've ever thought of, is sticking a needle in your penis. But I did 1 of 3 studies now. The first study that showed that actually sticking the needle in there doesn't usually hurt. It's a very fine, small needle. So that's not so much the problem. Is it a totally weird thing to do to yourself? And can there be side effects? Absolutely. There's lots of things to think about, but I would say the majority of men in my study, as well as all the men I've worked with over the years, most men do not find it especially painful. In my study, 40% of the men rated pain 0 to 10, 0. They said, I felt it go in, but it didn't hurt. And of the men who rated any pain 1 to 10, the average pain rating was between 1 and 2. And in subsequent studies, about 2 as well. So most men are surprised it doesn't hurt as much as they think. It still doesn't mean you should do this or this is for you. And some of the men who've tried this, just like the penile implant, love it and are so glad to be able to function again. They may tell you it's the greatest thing in the world, but it may not be the greatest thing in the world for you. And everything has good and bad. Make no mistake about it. I wish all these things didn't have their downsides, but they all do. So I will always tell you the good, bad, and ugly of it, because I promise you this. If I don't, you'll come back and tell me the good, bad, and ugly of it if I didn't tell you. So I tell you the pros, the cons, the good, the bad, the ugly, so that before you get into it, you can make your own informed choice and be empowered to decide what you want to do. And there is good and bad with injections, and I'm happy to answer questions about it. Let's go to the next slide. So, and there's also a penile implant surgery too. I'm not sure if I have a slide in there on that, but that's where they put cylinders in your penis, and it's the most invasive thing that we do. But it works. It goes where you go. Only about 1% of men will go to that more permanent thing, but the men who do it in their partners, about 80 to 88% of them are pretty happy with it, but there's good and bad with it too. There's also a pellet. Again, it doesn't work all the time for patients, so I may not have anything in there about it. I just wanted to touch on a few of the things, but there are different treatments. But if you don't have desire, one of the first things we want to do is rule out any kind of things that could be affecting desire. Things that affect your testosterone or whatever. Maybe you have a testosterone-dependent cancer, so we can't do anything about that, but we at least want to see what the underlying problem is. And then we may need to refer you to a psychotherapist or someone like myself. I'm a sexuality counselor, and where we kind of talk about and go over some different things and see about any kind of traumatic past experiences or things that might be affecting you. Sometimes we just try and get your brain engaged by simmering. Simmering can be a lingering sexual kiss. It can be sexual thoughts. It can be a hug that lingers. It can be cuddling, anything that kind of gets your mind in that sexual direction. Bibliotherapy is reading erotic things, romance or erotic literature that makes you think about sexual things. I like reading better because then you use your brain and your imagination a little bit better than some of the more explicit visual things like porn, because some people feel upset or inhibited by porn. Like your partner may feel like, well, now we have to live up to what's happening in the porn. So sometimes I find I find erotica in visual form helpful to some couples, and sometimes I find it hurtful. But most people do okay with bibliotherapy, reading about sexual things. So that's why I like that a little better. Sensate Focus is planned love play designed by Masters and Johnson, where we kind of get back to, sometimes we start with the basics. We just get you used to cuddling, and then we kind of get used to some touching, some non-genital play. We get used to genitals and then intercourse and all those things. So we work on desire in a lot of different ways. And I see there's going to be a question, and Carrie, I will get to that in just a second, and about desire with your treatment. Let's go to the next slide. I'm almost finished, and then I can start with your questions. So thank you. These are just some resources to help you. I have a whole library of on NorthShore of videos about the different treatments and the different things for men and women both. It's all free to look at. If you go on drjeffalbaugh.com, the book I wrote for prostate cancer patients is literally downloadable completely for free. If you want a hard copy of it, it's not expensive, but you can get it for free. If you want it, it's there to help you. Cancer.org has some great resources, cancer.gov. You can see that Sexual Health Matters is from the Sexual Medicine Society, but lots of good resources that can help you. And also NCCN has some, that's the National Cancer Network and stuff. So lots of good resources that may help you. NorthShore is the videos. If you just put in NorthShore, Sexual Health Videos, Albaugh, you'll find them. There's one for men and women. drjeffalbaugh.com is just my website for my book. So you, and I only created it so people could have it, so you can download it for free. We don't make any money off of it. The money that we get goes back into creating more resources for patients. It just goes back to the foundation. Anyway, so those are some resources. I think there's one final slide with my key points, which is just that sexual dysfunction is common with many diseases like diabetes, high blood pressure, cholesterol, head, neck, and back issues, but it is also very common after cancer treatment. Sexuality and intimacy can be addressed successfully, and we're hardwired. We need connectedness and intimacy in our lives. It's part of the human journey. And if you don't, and you have come to a place where that's not important to you and your partner, that is perfectly fine too. Whatever works for you and your partner is all that matters. Communication can be critical. So learning to communicate around sex and intimacy with your partner is super, super important. And lastly, I know, because I see it every day in my clinic, it is possible to have even a deeper, richer sexual, intimate relationship with your partner after cancer treatment. Because I've actually had people in my studies and in my clinic tell me it's deeper, it's richer, it got better because we started working on it in different, better ways. So I know it's possible to have that after cancer treatment. Now your questions. Carrie, thank you, because you already were the brave soul who submitted the first question. Yay, good job. Okay, so what do I want to say about that? So you talked about your desire, and so remember.
Dr. Albaugh, can you restate the question without personal detail, just so we can restate what you answered?
It's in the, it must be in the chat, so let me see. So the question was, my desire has diminished. Can T-cell treatment help? Okay, so first off, I'm not sure what you mean by T-cell treatment, but there's a couple things to think about. So